we're going to run through, we'll just really briefly talk about the course of the disease because it helps us decide how we'll make decisions with regards to prenatal and intrapartum management. I like to give a plug for communication between the inpatient and outpatient care settings. And then we'll talk some about the impact of COVID-19 disease on management of delivery. Just a brief review of pertinent physiology, more for the people who don't do obstetrics. You'll have the opportunity almost assuredly to interface with emergency room physicians or internists, hospitalists, who aren't aware of some significant changes for pregnancy physiology. Primarily, if there is apnea for any reason, hypoxia develops extremely rapidly, and that just needs to be, they need to know that for the duration of time between intubating, for example. And for all pregnant women, there's a respiratory alkalosis because of the increased drive to breathe. And the consequence of that is PCO2 is dramatically lower than it would be. So if someone who doesn't understand pregnancy went to interpret a blood gas and they saw what for everybody else would be a normal PCO2, that person is having an impending respiratory arrest. So that's where the obstetricians need to get involved early in care of ill COVID-19 patients. So this is just a brief look at the expected course for COVID, and you can see that it can be really long. The disease, one of the parts we worry about is this mild high viral shedding, and then people, if they get ill, takes all the way to day 10 just to get to the severe place of being intubated, and recovery can take a very, very long time, and a few people end up with a cardiomyopathy. And I'm actually kind of curious to see what happens because I worry that this might be a disease that could lead women to have a peripartum cardiomyopathy, and only time's going to tell for that. So this is just the spectrum of the disease, and you can see that a good proportion are mild and they just steadily get better, and the critical people almost assuredly get very sick. The disturbing part, of course, is that small subset of people who have mild disease who suddenly turn the corner and get critically ill. And so you just can't keep anybody off of your radar screen. Just gets a little scary. So again, that most people, since most people are mild and not many period of time where you're going to be peripartum, the vast majority of patients that you're going to provide care for this illness aren't going to be in the setting where we have to have this anxiety about delivery. Now, having said that, that's the part we need to prepare for. But for some reassurance, it's even, especially in a small unit, it's the likelihood of it occurring is not very high. So the disease is initially quite mild, but it bears mentioning several times that the worsening can be precipitous and acute, and you just have to watch people who are in that middle part of their illness very, very close, especially if they're in the hospital. They can get what we call a cytokine storm that ends up triggering people into ARDS and ultimately cardiogenic shock. And again, the deterioration can be quite rapid. So one of the things that you'll do in the clinic, there's decision making around evaluation, and there's a great tool. I'll look at the next slide that everyone probably has who does obstetrics to be able to assess risk factors and severity, and then make a decision about what you do next. I have no intention of people looking at the details of this slide other than saying these are helpful things to ask for severity, decide if they have risk, they got to go to the emergency room, and a little more detailed decision making about who can go to the clinic, who can stay at home. So it's just a handy tool, but we're not going to go through it. So the other thing I think is important is to do what you can in your community so you know what pregnant women are sick and what their setting at their status is at the moment, and be able to communicate this with labor and delivery. And what we're going to do, which is, you know, we're a fairly big unit, we're going to have a virtual COVID clinic patient set and just talk to the folks on the phone very carefully every day and decide who needs to come in and who can stay where they are, and then we can communicate with labor and delivery about who all these people are. So at each place that we're at, we need to sort of establish criteria where these admissions are going to happen before they come to the place. So if somebody has significant respiratory illness and that's their indication for hospitalization, you'll probably send them to a non-obstetrics ward. And we have a cohorted COVID ward. Smaller hospitals aren't going to do that. Obviously, obstetric care is going to have to come to labor and delivery, except for in the setting of acute illness requiring intensive care unit stay, in which case they would probably stay there. And for postpartum care, some places, Mass General just takes people right out of labor and delivery, even if they've had a vaginal delivery, and take them to a cohorted ward, which makes pediatric care quite challenging, of course. So there's pretty standard admitting criteria that everybody who's screening people for COVID illness know if they're getting significantly ill and really having respiratory distress and tachypnea, and especially if it's severe. And you have to take comorbidities into consideration. Someone who has asthma, for example, or diabetes is going to be managed and admitted earlier. People who you're talking to on the phone and just aren't getting any better and can't kick their fever, then they ought to come in. And certainly anybody who worries dehydrated should come in. So in pregnancy in specific, then we'd have to think about, do we have a lower threshold for admission in the third trimester? You still need to look at risk factors and conditions of the patient. Patients who are pregnant are no more likely to get significantly worse than somebody who's not pregnant, but right, there's the logistics of potentially need to deliver, getting your PPE ready, so it might be that you'll admit people earlier in the third trimester. And then the next things bring up, what are we going to do about testing if testing supplies resources are limited in any sense? There's national discrepancy on who does PCR COVID testing on symptomatic obstetric patients, regardless of gestational age or severity. And I've been in touch with places across the country, and that's been variable. And in fact, if you'd asked me 2 days ago, I would have told you that we don't test all symptomatic obstetric patients. And if you ask me today, we do. So anybody who calls in who has symptoms suggestive of COVID infection or exposures, they'll be allowed to come in and get tested. We just would like to know everything about our, what status our patients are and get them on our radar screen. So and I can't tell you what's going to happen next Monday because it will be different again. So the national quandary currently too is, what do you do about asymptomatic patients? Do you test all of these people? Do you test them before a procedure? Do you test them at admission, or do you stick with a plan of just testing for clinical illness for symptoms? And that's a moving target for sure. And one of the reasons it's come to everybody's attention is a very recent editorial published in the New England Journal, where 2 very large New York City hospitals screened everybody that walked in the door, and they found a disturbing number of people who were asymptomatic and PCR positive for SARS-CoV-2. So that was worrisome, and indeed one of the patients became symptomatic during the hospitalization, and one of the test negative patients became ill and had a positive screen. The other thing they pointed out was there could be more false negatives, right? Because all these SARS-CoV-2 negative people could have gone out and got sick a week later and still have been infectious at the time they were there. So in that setting, it got everybody's attention for sure, and they continued to screen. So making the decision whether or not to screen is a little more complex, right? Because the benefit or not lack of benefit depends a lot on the prevalence in the community. So if you're in New York City where there's the prevalence is high, well, then there's a high likelihood that testing is going to alter decision making. There may be scarcity still of ability to do testing. Cost needs to get involved. Really importantly, turnaround time. If you're in a hospital on the seacoast that I know of, your turnaround time is 7 days. So screening from that population is not going to be of much benefit. There may be PPE supply limitations, since you have to do full gear for everybody to do testing, because it definitely is an aerosolizing procedure. It's very hard to get a handle on the test performance statistics, meaning sensitivity and specificity. And the other thing that I worry about is the trap that if someone's test negative, that you consider them uninfected, because that's not necessarily true. And there are plenty of times when people get tested a few days later and then now we're demonstrated to be infected. So you just have to bear that in mind when you use that piece of information to manage how you're going to decide how you're going to manage labor and delivery, use of PPEs, et cetera. So decision making about delivery. For other viral respiratory illnesses like chickenpox, pneumonia, influenzas, it had never been demonstrated that delivery made a significant difference in the course of illness. So we always went with, you don't have to deliver for this, it's not going to make it better. And that may not be the case for COVID. There's more evidence that being delivered may actually be part of a therapeutic benefit for the patient. On the other hand, COVID-19 is not an absolute indication for ending the pregnancy, so that we wouldn't by any means deliver all the 28 weekers, for example, for somebody who had COVID-19. So when you decide about when to deliver, you got to take a number of things into consideration. So there's not going to be an easy algorithm or if this, then that, because there are things you have to take into account of the maternal condition, where they are in this disease course, knowing that people progress in very different ways, and knowing that the severity peaks in the second week, take that into account. And I already talked about how things may get better. Gestational age goes without saying, and observing what the fetal status is as well. Other decision making for delivery considerations: if you have an obstetric indication for delivery, early delivery, like a previa or preeclampsia, having a COVID infection does not indicate that you should wait. You ought to go ahead and get that patient delivered, because clearly if there's an indicated delivery, there's a downside to not doing it. So if you have a previa, then this patient could have a critical illness and then on top of it have heavy bleeding. So that would be an indication to proceed with plan A. One of the things that people are talking about currently is whether or not you try to stop labor, and for many conditions that's currently going to be considered not to be appropriate, partly because the medicines have some physiologic disadvantages, and partly because when we manage preterm labor, one of the things you have to do is make sure that this is not a baby that would be better outside. So that I always say to the residents is you make sure you're not closing the door on somebody who really wants to get out. The other thing that delivery can do is to make intensive care unit care a little more logistically easy. Prone ventilation is commonly utilized for COVID infection in addition to other ones. And frankly, it can be done to do prone ventilation. We've done it a couple of times. It involves a bazillion pillows to hold people in a safe position. But having said that, if you're later in the pregnancy, and prone ventilation is going to be more and more challenging, than being delivered for that individual would certainly make things logistically easier. The other thing that is done commonly with intubated patients is allowing passive hypercapnia. And since the babies need a gradient of acid base between mom and baby to be able to get them out, their personal acids out, we always worried about what would happen if the maternal CO2 was rising and kept it lower. But it turns out that babies can actually tolerate significant maternal hypercapnia, and people have run it as high as PCO2s of 60 and still seeing good fetal condition. It does make me a little nervous, but for an acutely ill patient where you're in a situation of an early gestational age, you might want to allow passive hypercapnia, because for ARDS, it does seem to be a therapy that's of great benefit. So how about the third trimester? So what do you do if you're somebody who's just starting to get symptomatic, she's at term, do you want to deliver that person? And I talked to my friends in Boston, and they say, yep, we offer it to people, but a lot of people just don't want to do that. They would prefer to roll the dice and think they're going to have mild illness and be able to be over it by the time they're taking care of a newborn. So it's a risk-benefit discussion. And then the question of what do you do in the preterm period, we talked about how it might make things better and safer, and it all depends a little bit on the clinical status about at what gestational age would it be safe to go ahead and deliver. Labor management, in the published series, which as you know are really small, there's just not that many pregnancies that have been collected in series for us to hang our hat on. In those settings, the majority of the deliveries were by C-section, but you don't know, is this because they were significantly ill? What's the cultural prevalence of doing cesarean section? And those influences that make it not clear to me that for sure that everybody has to be delivered by cesarean. And part of it is because vaginal delivery is going to facilitate recovery and facilitate discharge. So you don't have to have somebody who's has a significantly ill and then has a abdominal surgery and trying to recover from both. For managing labor, I like to think of it as you're managing somebody who's had 3 previous C-sections who wants a vaginal delivery. So you just don't tolerate things. You don't tolerate a protracted labor. You don't spend a lot of time pushing. You don't tolerate a category 2 tracing. And during any labor, with that would happen, you don't want to compromise the team and the patient for any emergency delivery, because it just takes a long time to get all the PPE equipment on, and then the delay will potentially harm the baby, and speed could potentially put a healthcare worker at risk. Putting an early epidural in, is anesthesiologists are thrilled about that, because that makes it much less likely that the patient would need to be intubated, which is clearly an aerosolizing event that puts everybody at some risk. It's okay to do a scalp electrode, it's okay to do an amniotomy and a vacuum delivery. The intrapartum issues, again, stress it, that's paying attention to vital signs like O2 sat, tachypnea, all kinds of data, because deterioration can happen rapidly. And so if you've got somebody in that phase of their illness, you want to make sure that your anesthesia, your critical care people in your operating room are all up to speed. And intrapartum, we've decided to do temps every 12 hours on support people, because the presumption is that they're PUIs, having been exposed to the symptomatic COVID positive patient. Preterm management, this won't apply to everybody, but it's kind of handy to know if you're referring patients. We are not going to be giving like preterm steroids or rescue courses of betamethasone, and the reason is the concern for corticosteroids prolonging the course of the illness, but a single course of betamethasone people feel is not going to harm anything. I already talked about how tocolysis is unlikely to be used. We use magnesium both for neuroprotection and for eclampsia prophylaxis. And because magnesium can impact respiratory drive, the notion is to limit it to the smallest dose and even not give it to somebody who's got moderate to severe illness, even if they have preeclampsia. So just briefly, don't read this whole thing. It's just the American Heart Association put out that, yes, indeed, if somebody has a cardiac arrest, you should do a perimortem cesarean section. And we know that you really ought to get at it by 4 minutes. The problem for COVID patients is you have to get into your PPE gear before doing that, and that clearly could prolong things. So we're going to have our COVID patients in the third trimester who are at all significantly ill be in the ICU. That could facilitate managing that situation. How to get out of using PPE, just really quick, the CDC's got 2 different strategies. You can do it by test-based, you can do none by not test-based, just by symptoms. And we'll just skip that. It looks like we're running out of time. So I just wanted to us to know the familiarity of the course of disease, so it's going to help us make decision makings for labor and delivery. A plug for very good communication between outpatient and inpatient care, and discuss the impact of the illness on labor and delivery. I think that's what I got.
Thanks so much, Emily. That was great. It's such a complex topic, and yeah, being a total non-expert, I can just see how the changing sands make it even more difficult to make recommendations. But I think that was a great summary of current state. If you can unshare, and I'm going to get Belinda to just share that one slide about use of the chat box would be great. So we're gonna open it up now for questions of Emily, and we'll ask our participants first from the network, and then we'll ask our panelists if they have anything to add. But before, I just want to go briefly over best use of the chat box. So we'd like all questions to come in through the chat box, and Vicki and Kelly are going to be monitoring that. Because we do have a large audience, we can't just make it a free-for-all for folks to come off mute. If your question is chosen by Kelly or Vicki, they will send you a private chat that you'll be able to see, just so that you'll know that you'll have a turn and you can be ready to come off of mute. You can just click again. When you do click the chat box, you should have the chat window, which opens on the right. And if you prefer not to have that taking up real estate, just one more click. There's a little down arrow at the top of your chat box where you can choose to close it out or pop it out and make it a free floating window. Okay, so we can get rid of the slides now, and I am going to turn this over. I'm not sure if Kelly's internet is working or if Vicki's going to do this, but we'd like to select some of these questions from the chat box to go to Emily.
Yeah, Eleanor Gardner had a question. Eleanor, would you unmute and ask your question, please?
I am a nurse midwife at a critical access hospital in Vermont, and I'm just wondering what the reasoning is behind early epidural in laboring COVID positive women.
The anesthesiologist, and I think it makes sense from my standpoint too, is that having an epidural, even if you're not running it high, to a high level, then that's going to give the ability to do a cesarean section and decrease the chance that you're going to have an intubation on an urgent basis, because intubation is just so aerosolizing, and anybody in the vicinity then is significant risk of getting an exposure. I don't think it's mandated, but I think it's a reasonable suggestion of how to protect the need for a general intubation.
Great. And P. Stewart, would you unmute and ask your question, please?
Yes, this is Peter Stewart, and I'm an OB at North Country Hospital. I'm wondering if there is an O2 sat below which you would do your, below which you would just say we have to do a C-section at that saturation.
Yeah, that's a great question. When you're taking care of somebody who's acutely ill, you definitely try to keep the O2 sat above 93. And then, so anybody who's persistently in the low 90s and for sure in the high 80s, that kid's just not going to be getting enough oxygenation to be sustained doing well. And for these folks, I would suggest that we have them on continuous monitoring for two reasons. One is baby monitors are fantastic mom monitors. If the baby's starting to look unwell, then the mom could be deteriorating soon. And also, that if it starts to desaturate, mom gets low enough, then the baby's just not going to tolerate that. So really low 90s, high 80s, if they can't, like maximal support and can't get it up higher, then that's a setting in which delivery is likely indicated.
Okay. There is someone named L. Nussbaum. Would you unmute and ask your question, please?
Hi, this is Leah in Brattleboro. I just wanted to clarify that you are allowing significant others, domestic partners, to be the essential labor support, even though they're assumed to be PUIs. And then as a follow-up, what are you doing in terms of providing PPE for support people?
Yes, we are allowing support people who are sort of by definition PUIs to be at support. They come in the room, they get a mask on, just a regular mask, and then after delivery, then we have them leave. Having them there, we know increases the risk to the staff, but since everybody in the room is in full regalia PPE, the infectious disease people felt that it was safe to allow PUI support people to be in the room.
Great, thank you. And that's just a surgical mask that you give?
Yeah.
Dr. Abigail Masterman has two questions. You can ask both of your questions, Abby.
So the first is for patients who have mild illness in early pregnancy, including the early third trimester, and have recovered, I'm curious what departments are actually doing to clear these patients. And currently we have two areas set up, one our regular labor unit and then a different space where we've set up another laboring or evaluation area off the unit. And so I'm curious if we could take somebody who's ever been positive and put them back in the regular labor unit, and what you guys are doing to kind of prove that. And then my second question is what everybody is doing. If you're not doing universal testing, are you all wearing PPE like N95 and face shield for the second stage of labor for all patients, including those that are asymptomatic and not PUIs?
Yeah. There's a national consistency about what to do for everything, but for what to do about clearing somebody. And to my knowledge from talking to people, I think they're relying on sort of the CDC's when you can get rid of your equipment.
Mm-hmm.
And relying more on testing strategies. But again, it's all about what do you have for ability to do testing. So I don't know that there's a universal answer for that. And then with regards to second stage, if you'd asked me Friday, we weren't doing anything different. But you asked me today, we do have access to N95s for second stage for everybody. There's no national consistency about that. My friends at Tufts in Boston don't do that. They don't provide N95s for everybody.
Mm-hmm.
And I think Partners is now, I'm not sure, but I know there are other places that are doing universal N95s.
Yep.
Again, it's all, do you have them, right? If you've only got two, you're not gonna give them to somebody who's pushing who doesn't have it.
Thank you.
Sure.
And this question might actually be for Dr. Ringer, so I'll give you a heads up on that. Sharon Vupolo was not able to unmute and use her microphone, so I'm going to ask the question from her. Are folks testing newborns born to mothers who are PUIs? AAP is recommending testing, and the CDC recommendations aren't clear on the newborn testing.
Yes, that's correct. So I think one of the goals would be testing, but it because I think it aids you in particularly guiding the family for post-discharge management. Of course, as testing becomes more available, then you're more likely to be able to get testing on the mother before the baby leaves the hospital. With all that said, the general recommendations, if you are going to test, are to bathe the baby after birth and then test once at 24 hours and then to repeat at 48 hours. But I think in general, what we're finding is that in most instances, the issue is resolved one way or the other. Either the mother is known to be positive, in which case it's makes good sense to test the newborn, or is already known to be negative. I don't know if that completely answered your question.
So I have one more question before we turn over to the case presentation and questions. There'll be more time for questions after the case presentation, but I'm going to ask Zach Dean to unmute and ask the question.
Sorry, it's Nancy Parisser, that's my son's. The question was, I've been assigned to look at all kinds of protocols, to utilize our protocols at Southern New Hampshire Medical Center. And the one unusual one I saw after looking at Brigham and several others, that they made mention that they would not recommend an ICU delivery at bedside, say a person is deteriorating, that they didn't go into detail, but said avoid, and even if it's perimortem. Can you comment, Emily?
Yeah, sure. I mean, I don't think anybody could want to take somebody else away to go do a perimortem one, since you have to get it done within 4 minutes, right? So if you've got somebody in the ICU who has a cardiac arrest, you're going to want to do that right where you're at. And then your other question was just doing delivery in the ICU in general or by C-section. Would you mind repeating it?
Yeah, they were saying, I think what they were meaning, again, it's just printout, was that they just made a statement to avoid all cesarean deliveries in the ICU. And I assume that means that they would want to transport anybody that was going to be delivered by cesarean rather than doing them at bedside, which didn't quite make sense. And then they made that second comment about avoiding a perimortem.
Yeah, avoiding a perimortem one is probably good practice, but then in terms of where you deliver, I think if someone's ill enough that you think that you're going to make their care better and you've got some time and it's urgent, it's not emergent, then moving to a main operating room has all kinds of advantages. The room's bigger, you've got all kinds of extra support. I have done C-sections in a ICU for someone who had deteriorating chickenpox pneumonia. You can do it. It's just by no means ideal. You'd much better be in a main operating room to do a delivery.
Thank you.
Sure.
Great, thanks for that.